afternoon, everyone. Thank you so much, Mr. Chairman, for the kind introduction. I'd like to thank the organizing committee for the kind invitation to participate in this interesting meeting. My name is ABDELHAMID from Egypt. I'm the co-chair of the educational committee of the Heart Failure Association of the European Society of Cardiology as well. So in a couple of minutes, I'm going to cover the optimal medical treatment and what are the new drugs which we have for treatment of patients with chronic coronary syndrome. And I will take the one of the statements from the last slide, interesting slide about optimal medical treatment, because we need to give the patients optimal medical treatment, because the goals of therapeutic treatment is to relieve symptoms and to improve prognosis. So how can we achieve this? Through drugs which increase coronary artery blood flow, like nitrates, dihydropyridine calcium channel blockers, nicorandil, drugs which decrease myocardial oxygen demand, like beta blocker, CCB, ACE inhibitor, ivabradine, trimetazidine, ranolazine, halt the progression of atherosclerosis, of course, by the use of statins, and finally, to prevent development of acute coronary syndrome through the use of antiplatelets. So we have the last EC 2019 for the guidelines for management of patients with chronic coronary syndrome, class 1C recommendation that medical treatment of symptomatic patients require one or more drugs for treatment of myocardial ischemia and the relief of angina in association with drugs for prevention. So we know that short-acting nitrates is just to relieve angina. However, the first-line treatment should be beta blocker and or calcium channel blocker to control heart rate and symptoms. If angina is not controlled, we have the option to add both combination of beta blocker and the calcium channel blocker, class 2A recommendation, or class 2A to initiate combination from the start, and long-acting nitrates is class 2A, a second-line treatment for patients who have angina not controlled by the first-line treatment. So what about the drugs which are considered to be new? It's not too new, because we have the evidence from some clinical trials for the use of nicorandil, ranolazine, ivabradine, trimetazidine, which are considered drugs to reduce angina, to improve exercise tolerance in patients who cannot tolerate first-line treatment or have contraindication for these drugs or have symptoms which are not adequately controlled by the use of beta blocker, calcium channel blockers, and long-acting nitrates. And in patients with low heart rate and low blood pressure, we should give drugs which have no hemodynamic effect, drugs which does not decrease heart rate or blood pressure, like ranolazine or trimetazidine. And this slide summarizes the available drugs, first-line drugs, beta blocker, verapamil, diltiazem, dihydropyridine, short-acting nitrates. The second-line drugs, ivabradine, ranolazine, nicorandil, trimetazidine, long-acting nitrates. Lifestyle modification, statins, aspirin are important. And this slide shows you can combine both drugs, 2 drugs or 3 drugs to control angina, but you have to be very cautiously in combination of drugs which slow the heart rate, like diltiazem, verapamil with ivabradine or beta blocker. So let us to see the evidence from the use of these drugs, like nicorandil, for example. It's a vasodilator. It increases oxygen supply, decrease preload and afterload, it decreases myocardial oxygen consumption, effective on small arterioles. The evidence from the trials that the use of nicorandil could relieve angina and decrease the risk for major coronary events. So through the mechanism of an ATP potassium channel opener, it acts on the vascular smooth muscles in the arterioles. It increases the coronary blood flow, it decreases the afterload, and it has an effect on the mitochondria and the cardiac myocytes to lead to preconditioning, which can lead to prevention of secondary myocardial infarction, a nitric oxide donor through preload reduction, acting specifically on systemic veins and the epicardial coronaries. So this is one of the studies which involved more than 2,000 patients, the IONA study, Adding ranolazine to anti-anginal drugs compared with placebo, looking for the primary endpoint of the study, which is a coronary artery disease death, non-fatal myocardial infarction, or unplanned hospitalization for cardiac chest pain. And the use of nicorandil was associated with statistically significant reduction in the primary endpoint, a 17% relative risk reduction in favor for the use of nicorandil. What about ivabradine, which slow the heart rate, negative chronotropic effect, decreased myocardial oxygen consumption, increased duration of diastole? The evidence from trials that increased time to ischemia during exercise and decreased the rate of hospitalization for worsening heart failure. So we know ivabradine acts specifically on the SCE node. It decreased the intrinsic activity of the SCE node through IF current inhibitor. So this will lead to decrease or reduction in diastolic depolarization slope, slowing the heart rate. However, in beautiful study, which included patients with chronic stable angina and LV systolic dysfunction, unfortunately, the use of ivabradine was not associated with significant reduction in the primary endpoint. However, in sub-analysis, it decreased coronary artery disease outcome in subgroup of patients with heart rate above 70 beats per minute. So the benefit of using ivabradine in patients who are on beta blockers but still have a heart rate 70 beats per minute or more. And this slide shows the evidence from the beautiful trial that in patients with limiting angina and even angina with heart rate more than 70, if you look for the composite primary endpoint, it was not statistically significant. However, on the right, you can appreciate that the use of ivabradine was associated with a reduction in hospitalization for fatal and non-fatal myocardial infarction in patients with limiting angina and limiting angina and heart rate more than 70 beats per minute. But unfortunately, the use of ivabradine in Signify study was not associated with a significant reduction in the primary endpoint in terms of cardiovascular death and myocardial infarction. You can see here the primary composite endpoint with the use of ivabradine in Signify was not statistically significant, and also death from cardiovascular causes and non-fatal myocardial infarction. What other drugs that we have? We have ranolazine. Ranolazine, it decreased ventricular wall tension, it decreased myocardial oxygen consumption, decreased fatty acid beta oxidation, increased myocardial oxygen efficiency. So the clinical findings is associated with increased exercise performance, increased time to ischemia during exercise, and decreased hemoglobin A1c. It has an anti-arrhythmic effect. We know well the cascade of myocardial ischemia, the pathophysiology of myocardial ischemia, and once ischemia occurs, there is increased late inward sodium current. So this will lead to increased sodium overload, followed by increased calcium entry. And the calcium overload is associated with a harmful effect in terms of arrhythmia, electrical dysfunction, mechanical dysfunction with increased diastolic tension and decreased contractility, increased ATP consumption, decreased ATP formation. So through the use of this drug, ranolazine, which is a late sodium current inhibitor, this can alleviate the bad effect of ischemia on this pathway, which will lead to an anti-arrhythmic effect, increased contractility, decreased diastolic tension, increased ATP formation, and decreased ATP consumption. We have an evidence from some studies which demonstrated the benefit of ranolazine, such as the CARIZA study, which involved the patients who have angina not responding to anti-anginal drugs. So the objective to assess the effect of ranolazine when added to standard anti-anginal therapy, randomized, double-blind, placebo-controlled trial, 800 patients with symptomatic angina in a dose of 750 milligram or 1,000 milligram twice per day. For 12 weeks, the use of ranolazine was associated with increased exercise test parameters with the use of both drugs, both doses, 750 or 1,000, compared with placebo, as well as decrease in the angina frequency parameters. Finally, trimetazidine decreased fatty acid beta oxidation, increased myocardial oxygen efficiency, it increased peak exercise duration, and time to 1 millimeter S-segment depression. And recently, we have the evidence that atherosclerosis is an inflammatory process. So colchicine, which acts through an anti-inflammatory effect, could lead to inhibition of neutrophil function, interference with neutrophil platelet pathway, and this will lead to reduction in the risk of acute myocardial infarction and ischemic stroke, reduction in the risk of coronary revascularization, reduction in the risk of cardiovascular death. And we have one study, which is the Ludoco trial, and in this study, adding colchicine in a dose of 0.5 milligram compared with placebo for patients with chronic coronary disease, the risk of cardiovascular events was significantly lower with the use of colchicine. So we look for this slide, the primary endpoint, cardiovascular death, MI, ischemic stroke, schema-driven revascularization was statistically significantly lower with the use of colchicine compared with placebo, and the same for the key secondary endpoint, cardiovascular death, MI, and ischemic stroke. So the recommendation by the American guidelines, class 2B recommendation in patients with chronic coronary syndrome to add colchicine in a dose of 0.5 milligram per day. This is the take-home message that patients with chronic coronary artery disease, optimal medical treatment is important. And to relieve angina and improve symptoms and quality of life, in patients with effort-induced angina with heart rate more than 80 beats per minute, beta blocker, non-dihydrogenase calcium channel blockers, ivabradine, ranolazine, trimetazidine are good options. In patients with bradycardia, dihydrogenase calcium channel blockers, amlodipine, long-acting nitrates, ranolazine, trimetazidine, nicorandil are good drugs. For patients with low blood pressure, you cannot give drugs with low blood pressure like CCB or beta blockers, so ranolazine, ivabradine, trimetazidine can be given. But you have to consider the etiology. Some patients have vasospastic angina or microvascular dysfunction, so those patients have the benefit from using drugs which are vasodilators like calcium channel blockers, ranolazine, beta blocker, and non-dihydrogenase calcium channel blockers. Microvascular dysfunction can be treated with CCB, nitrates, or nicorandil.